welcome everybody to the Novo Nordisk Network virtual seminar series. Thank you for joining us today. We're really pleased to be able to present our speaker, Dr. Gillian Booth, who's going to be speaking on the weight of place, the built environment, and diabetes risk. Before we start, I would like to start by acknowledging the traditional land on which University of Toronto operates. For thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississauga of the Credit. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. So before I introduce you to today's speaker, I'd like to quickly let you know about some updates for the network. First and most importantly, the Novo Nordisk Network for Healthy Population is starting 2023 with a brand new website. Please visit our website at healthypopulationsnetwork at utoronto.ca. We'll put it in the chat for you to find out our latest news, updates on future events, funding opportunities, and much more. Our team will be adding some more content as the network grows, and we welcome feedback on information our members would find helpful. Another exciting announcement from our network is that our seminar sessions, including today's session, are now CME accredited. Now, this is mainly relevant for our healthcare professionals who need to collect continuing medical education credits, or CME credits, when they attend educational activities that help them to maintain, develop, or increase their knowledge, skills, and professional performance. So for today's session, if you would like CME credits, please email us at director.novonordisk@hp@utoronto.ca. We'll put that email in the chat. And and we will be adding this to our registration moving forward, and credits will be issued annually. Now, I'd like to review some housekeeping notes. We appreciate our audience muting themselves during today's presentation. There will be an opportunity for questions at the end of today's session, and we will be inviting questions both through the chat box or by using the raise hand function. Please save your questions till the end just to make sure that we have that Dr. Booth has enough time to do her presentation. However, if you do have questions during the event that you would like the speaker to address at the end of the session, you can enter them into the chat box and we'll be collecting them, and as much as possible, we'll address them at the end. And please note, lastly, that today's session is being recorded, and we will make the recording available on the network's website. Now, without further ado, I would like to introduce our speaker today. I am so thrilled that Dr. Gillian Booth, who's a close colleague of mine and has been an active member of our network since the beginning, has agreed to speak to us today. Dr. Booth is a professor in the Department of Medicine and the Institute for Health Policy Management and Evaluation at the Dalla Lana School of Public Health at the University of Toronto. She's also a scientist at the MAP Center for Urban Health Solutions at St. Michael's Hospital, a Senior Adjunct Scientist at ICES in Toronto, and she also holds a Canada Research Chair in Policy Solutions for Diabetes Prevention and Management. Now, it goes without saying that Dr. Booth is an internationally renowned leader in diabetes health services research, with extensive experience in investigating how socioeconomic, environmental, as well as healthcare factors influence the risk of diabetes and its complications. One of her major research interests, which she will talk about today, involves the role of the built environment and our urban settings as a risk factor for diabetes and other cardiometabolic diseases. Dr. Booth has made major contributions to diabetes policy and practice in Canada through her many scientific advisory roles for government as well as non-governmental agencies, and notably as the methods chair for 2008 and 2013 Diabetes Canada clinical practice guidelines. So now it's my great pleasure to pass the mic on to Dr. Gillian Booth and ask her to get started on telling us about the weight of place, the built environment, and diabetes risk. Thank you, Dr. Booth.
Thank you so much, Lorraine, for that kind introduction, and I'm thrilled to speak to you today. I just need to scroll here. I do not have any disclosures to report. And the objectives of today's talk are to demonstrate how the built environment in which people live affects diabetes risk, to describe the interplay between environmental factors which influence diabetes risk, and to discuss the role of public policies targeting the built environment and of interdisciplinary collaborations as a means for diabetes prevention. So first of all, I'm going to take you through some key concepts. Firstly, I'm going to focus on neighborhood walkability in health, which has been a big focus of my research program. And just to, many of you are probably aware of this, but just to remind you that older, more traditionally designed neighborhoods tend to be more walkable for many reasons. They have a higher population density, but importantly, they're zoned such that retail and services are embedded within neighborhoods, so there's more places people can reach on foot. This is an aerial view of Manhattan showing the grid-like street pattern, which is common amongst older cities. And that results in shorter block sizes, and it's also been linked to higher rates of walking. Newer suburban developments, on the other hand, have opposite characteristics, so a lower population density, what we call as urban sprawl, as well as fewer connections between streets. And importantly, they're zoned typically purely for residential purposes, which means that stores and services and other amenities are separated and far away from where people live. So there's fewer places that people can reach, what we call walkable destinations. And there's a mountain of evidence now showing that less walkable neighborhoods are in fact associated with less walking, lower rates of physical activity overall, and higher levels of obesity. And I'll show you that data. It also means, if you live in a less walkable area, that you're more reliant on automobiles, and that means spending more time in cars. And based on a systematic review from Gavin McCormick and others have looked at this, that the longer time spent in a car, particularly 30 minutes or more per day, is associated with a higher body weight. It's also an opportunity cost. So if you're spending more time engaged in passive forms of transportation, so not getting physical activity while you're commuting, it means that you have less time to engage in active transportation, which we call walking, cycling, or public transit use. This is data from the UK Biobank, and compared to people who, the reference category of people who use cars only for commuting, people who on the right who engage in active forms of transportation, so using public transit, walking, or a mixture of cycling and walking, have a significantly lower BMI. And so you can see not only is driving as a form of commuting associated with less activity and higher BMI, and you can kind of see this gradient as you go towards, more active forms of transportation, such as cycling or walking. But the UK Biobank data, they also found higher CVD rates, so cardiovascular disease, cancer incidence, and cancer mortality amongst people who drive more, and lower levels in those who are more active in their transportation. So the IPEN study, was a big international study that's followed almost 7,000 adults living in 14 cities across the world. And what they found is that people who had high scores in their neighborhood for all three characteristics, so high walkability, high access to transit, and high access to parks and trails, accrued 70 to 100 additional minutes per week of moderate to vigorous physical activity. And that's about half of the 150 minutes that Health Canada and other national organizations recommend that we get every week to maintain health. There's also evidence that people living in more walkable areas have 75 additional minutes per week of utilitarian walking, as well as, so utilitarian walking is walking for errands, for commuting, so for a purpose, as well as higher step counts overall. And there's some really interesting data from a team at Stanford who published in Nature a few years ago using smartphone data on over 700,000 individuals worldwide. And what they did is they looked at the pattern of step counts in each country. And you can see in the panel on the left that Japan, the blue line, that population has a higher mean step count compared to, say, UK, USA, or Saudi Arabia. But they also found that if you look at the spread of the distribution of step counts in the population, there's a much narrower distribution in Japan, meaning more people are getting closer to the mean in terms of their step counts. And when you have a more skewed or wider distribution, you have a larger proportion of the population not having many step counts. So they call this activity inequality. And you can see in the panel on the right that countries that have higher rates of activity inequality have a higher proportion of their population who are obese. You can see Canada is sort of higher up on this curve. They also related this to the walkability of cities. Looking at US cities, they found that living in a very walkable city, such as New York, Boston, or San Francisco, was associated with lower rates of activity inequality compared to a more sprawling city, such as San Antonio, Fort Worth, or Houston. And you can see just the pattern for people living in high walkability areas. You can see higher step counts per day during the weekday at times of commuting, and in the middle of the day, you're going out for lunch, and on the weekend throughout the afternoon, compared to people in blue who live in a low walkability area, or low walkability city in this case. So just to summarize those key points, people who live in more walkable areas actually walk more and are more likely to meet physical activity targets. High walkability, therefore, may shift the population towards achieving more steps per day. And this also seems to correlate with rates of obesity. This is a recent study that's quite interesting that came out of the CDC 500 Cities project. And what they did is they used satellite imagery to look at built environment characteristics. And they found that 60% of the variation in obesity rates across neighborhoods was actually explained by the built environment. And you can see for Los Angeles on the left are actually obesity rates predicted by built environment characteristics alone. And on the right are actual obesity rates in the population. You can see that the patterns are virtually identical. The same was true for San Antonio and other cities, where you can see that the predicted probability of obesity based on the built environment really mirrors that on the right of actual measured obesity in the population. So that kind of brings us to the question, is neighborhood walkability a risk factor for diabetes? So we looked at this question quite a long time ago. Actually, this is a map from our Toronto Diabetes Atlas that Rick Glazer and I co-created. And we found that, that the highest rates of diabetes in Toronto were in Toronto's inner suburbs. These are the areas in red, compared to the more central areas and the areas in the Southwest. Now, this does correlate with ethno-racial compositions of neighborhoods, as well as the distribution of wealth in the city. But we found that only 50% of the variation across neighborhoods in terms of diabetes risk was explained by these key population risk factors. And there's 50% that was unexplained, which kind of made us turn to looking at the built environment. So we created a walkability index for Toronto. And many of those features I mentioned to you, you can measure using secondary data. So for example, we can look at how sprawling versus compact a neighborhood is using population density and residential density from the Canadian census. We looked at this layout of streets using map files to look at street connectivity, which is the number of street connections per square kilometer. And you can look at zoning differences in a number of ways, but we looked at the number of stores, services, and other destinations within a 10-minute walk of the center of each neighborhood. And you can see that this is done by creating boundaries around the center of each small neighborhood units, and then overlaying point destinations on top of that. And we came up with a composite score that included all of these items. And so we've been able to study whole populations by linking neighborhood level data, in this case on walkability, to all of the residents in a given area using provincial health records and linking people based on their postcode of residence. In this way, we can follow whole populations over time for adverse health outcomes. And so we looked at neighborhood walkability and diabetes incidence over a 5-year period among adults who were young and middle-aged, so 30 to 64 years of age, living in Toronto. This is 1.6 million men and women. And you can see that amongst both recent immigrants on the top and long-term residents, that if we look at Q1, which is the lowest walkability quintile, we found a 30 to 50% higher risk of developing diabetes over 5 years compared to the lowest the lowest walkability, highest risk compared to high walkability. And if we look at a systematic review, this was done by Nicole Den Braver from Amsterdam UMC a few years ago, and she found overall about a 20% lower likelihood of diabetes in high walkability settings. Quite a bit of the data here was driven by our studies, and many of the studies were cross-sectional and not longitudinal. But even if we do look at this using longitudinal data and we try and control for factors, we need to be cognizant that there are a lot of confounders. For example, self-selection is a big factor. So people who prefer to live in suburbs may be systematically different than those who prefer to live in urban areas and vice versa. And we have to remember that we need to think of how to account for systematic differences across populations, because not all neighborhoods are created equally, and the context in which people live their life is quite different. So we used a propensity score method called inverse probability of treatment weighting to create propensity scores that reflect the likelihood of living in a high versus low walkability area, and created individual weights that we applied to the population based on a number of characteristics, including age, sex, comorbidities, high blood pressure, previous MI, stroke, healthcare utilization, and area, socioeconomic status, and ethnicity. And we looked at the 10-year incidence of diabetes in those living in high versus low walkability areas. You can see that in all 5 regions, we looked at Toronto, the Greater Toronto Area minus Toronto, Ottawa, Hamilton, and London, that in each region, there was a significantly lower likelihood of developing diabetes over 10 years in those in the highest compared to the lowest walkability areas. And there was a summary hazard ratio overall of 0.85, meaning a 15% lower likelihood. So another question we asked is, are walkable neighborhoods experiencing a slower rise in obesity and diabetes? So this is data from the Canadian Community Health Survey. We looked at the rate of overweight and obesity in the working age population, age 30 to 64, living in 15 municipalities in Southern Ontario. And if you just focus on the orange line here, that's the highest walkability neighborhoods. We found that they had a 10% lower rate of overweight and obesity, and the rates were stable over a 12-year period compared to the 4 lower walkability categories, which had higher rates of overweight and obesity and a significant increase, although small, but a significant increase in obesity over time. We also found a similar pattern looking at diabetes incidence, in that the highest walkability area in orange again had a much lower rate of diabetes incidence. This is based on administrative data. And in fact, incidence decreased over that period of time in the most walkable areas. And this was adjusted for age, sex, income, and ethnicity. The only discernible difference we found between groups was their transportation mode. So using data from the Transportation Tomorrow survey, we found that these highly walkable neighborhoods had much higher rates of walking and cycling per capita, higher rates of public transit use per capita, and substantially lower rates of car use per capita. We didn't see any significant difference in terms of fruit and vegetable intake, and we found small differences in their rate of physical inactivity based on their leisure time activities. So that's an example where we followed neighborhoods over time to look for differences in disease risk. Another way you can look at this is to look at neighborhoods that have been intervened on. In this case, there's systematic review looking at new public transit developments, light rail transit, subways, buses, etc. And what they found is overall in the systematic review, an increase in light to moderate physical activity equivalent to walking an additional 30 minutes per week amongst those living near intervention sites. That may seem like a small difference, although on a population scale, it might be still very important. And there was quite a bit of variation across studies, with some showing an additional 20 minutes per day of walking amongst those living near these interventions. Another way of looking at this is to sort of follow, we think of this as sort of a natural history or a natural experiment. You can follow people who move from one type of neighborhood to another. So this is data from Samantha Hajna in Montreal, who was working with Kiberi Dasgupta and Nancy Ross. And she used data from the National Population Health Survey, the longitudinal sample, and follow them over time retrospectively. And what you can see is people who live in a consistently low walkability neighborhood, and the dotted black line, have a higher rate of, have a higher BMI. Not surprisingly, BMI goes up as people age. But you can see in green that people who moved from a low to high walkability neighborhood experienced a more shallow increase in BMI over time. People who lived in a high walkability area the entire time had a lower rate of a lower BMI over the period, but those who moved from a high to a low walkability area had a steeper rise in BMI over time. We've also found quite a bit of heterogeneity in response to the built environment. In our work, we found that older age groups, so people over age 65, appeared less susceptible to walkability, at least in the way that we're measuring it. And young adults seem to be more susceptible to with respect to diabetes incidence. And I'll just show you an example of this from Nicole Den Braver from Amsterdam, who's doing part of her PhD with me. And this is under revision right now at Diabetes Care. And Nicole used principal components analysis to create a novel index for Toronto that was a neighborhood drivability index, quite similar to the opposite of walkability, but she used more variables that were related to driving, including pedestrian facilities and parking infrastructure within neighborhoods, as well as measures of sprawl. And what she did was linking this to administrative data, looked at diabetes incidence in highly drivable neighborhoods amongst 1.5 million working age adults in Toronto, and dividing this up into those in blue who were age 20 to 34, to older populations who were age 55 to 64 in purple. And what you can see is that overall, there is an increase in diabetes incidence in all groups amongst those living in highly walkable neighborhoods compared to those in high drivable neighborhoods compared to less drivable neighborhoods. But you can see that overall, it's the younger populations who seem to be most susceptible and had the biggest increase in risk. And interestingly, this is a pattern that's seen throughout all of the age groups, that the people who are at particular risk were those living in middle income neighborhoods and lower likelihood or an increase in risk, but less so in populations in the lowest and highest income groups. And so those living in middle income groups who were under age 45 had almost a twofold increase in diabetes incidence living in a highly drivable neighborhood. We also found some differences across immigration status. So this is looking at the adjusted odds of gestational diabetes by walkability deciles, not quintiles. So, and you can see that as you get up to the top decile, we see a steep drop in the likelihood of having gestational diabetes in pregnancy, but particularly so amongst Canadian-born women. We found a significant reduction in GDM risk in the women born outside of Canada, but less so. It's not clear whether this relates to the degree to which people walk in pregnancy or other factors. Giselle Fasley in her PhD found similar findings looking at prediabetes incidence. She found amongst immigrants to Canada that prediabetes incidence was increased in low walkability areas, but among some but not all ethnicities. And in fact, in the South Asian population in this sample, there was no difference in prediabetes incidence amongst those living in low walkability and high walkability areas. There's a lot of different factors, however, that can actually have an interplay with walkability and could mitigate the effects of walkability. So one of them is air pollution. So for example, this is data from the city of Vancouver. You can see highly walkable areas in the deep red on the left, and some of these areas also have high concentrations of NO2, which is the key pollutant from idling cars. And in fact, this correlation was even stronger in lower income neighborhoods. There's mounting evidence that air pollution is associated with metabolic disease, and specifically air pollution has been associated with an increased risk of diabetes development. This is data from Nicholas Howell, who's doing his PhD with me, using data on 44,000 individuals in primary care identified from the Emerald database created by Karen Tu. And what he found is that if you look at neighborhoods in our study area, again, this is the 15 cities in Southern Ontario who are in the database, those living in areas that had lower levels of traffic-related pollution, so low NO2 concentrations, you can see that high walkability was associated with a significant reduction in the likelihood of having diabetes or hypertension. Whereas if you live in a high traffic pollution area with high concentrations of NO2, you can see that the benefits of walkability are virtually eliminated. Interestingly, Nick also found higher smoking rates in highly walkable areas and 26% lower rates of smoking in more suburban or lower walkability areas, even after considering differences in age, sex, ethnicity, comorbidities, and area income. It's not clear if this is related to easier access to tobacco through corner stores in highly walkable areas, or if it has to do with, other characteristics that we couldn't adjust for, the populations living in downtown urban areas. But it's another factor that could influence cardiovascular risk and diabetes. So when he looked at this, low walkability areas had lower rates of smoking, but on the other hand, they had more unfavorable health profiles and risk factors such as higher rates of systolic blood pressure, higher rates of diabetes, and lower HDL cholesterol concentrations. So overall, people living in a low walkability area had a higher predicted cardiovascular risk using the American College of Cardiology and American Heart Association risk score of a threshold of 7.5% over 10 years. He then used administrative data to look at the population risk of cardiovascular disease in adults 40 to 60 years of age. And he found that people living in a high versus low walkability area had a 13% lower rate of major adverse coronary events, cardiovascular events, as well as a 24% lower rate of acute myocardial infarction, 9% lower rate of stroke, and no significant differences in cardiovascular death for reasons that we can talk about in the question period if you like. It was a bit of a complicated analysis that needed adjustment for a lot of variables, but importantly, he adjusted for time, walkability and air pollution as time-varying covariates, as well as socioeconomic status and other factors. Another way highly walkable neighborhoods may be not good for you is if you're going to walk to fast food. Jane Polsky, who's now at Stats Canada, found in her PhD and postdoc work that living near a fast food swamp, so an area that has a high concentration of fast food, but has no other alternatives in terms of non-fast food restaurants, those areas were associated with a 1.5 to 2-fold higher rate of obesity, diabetes, and hypertension. So another area measure that, or a feature that can be very protective in terms of diabetes potentially, are access to parks and trails. And these are just showing some of the parks and trails in the city of Toronto. We know that from a variety of studies that access to parks and green space, or living close to these features, are associated with higher rates of physical activity and lower levels of obesity, diabetes, hypertension, cardiovascular disease, and even all-cause mortality. We also know that there may be synergistic effects of walkability and park access. And in fact, people may use green space or green corridors as a means of active transportation, particularly as a way to cut through neighborhoods and get from one place to another. And in work that Giselle Fazli and I have done, Giselle found that looking at high versus low park access, even in the highly walkable areas, having good access to parks was associated with an increase in physical activity. In this case, large access to lots of large parks was associated with a boost in leisure time physical activity, possibly because of access to trails, and having more small and medium parks close by was associated with a higher rate also of active transportation. Less walkable areas, park access was still associated with an increase in physical activity of all kinds, but to a lower level than if you could walk easily to those spaces. There's a lot of factors that seem to mediate improved health outcomes associated with green space. For example, as I just showed you, that green space is associated with increases in physical activity. And there's data to suggest that if people exercise in nature, that they're more likely to continue to do so. And that may be because of these other co-benefits that green space gives people. For example, there's been substantial evidence that walking within and spending time in green space is associated with a decrease in depression scores, anxiety, stress, and rumination. In fact, a randomized trial that happened at Stanford, they randomized people to walk within their green campus versus walking along the busiest street in San Jose. And they found that the centers in the brain detected on functional MRI that are associated with rumination actually lit up in those who are walking on a busy street and not in those walking in nature. There's also been evidence that time in nature is associated with improved cognitive function, memory, focus, attention, and sleep, as well as improved social well-being. So opportunity to socialize with people, particularly during the pandemic, so improved social cohesion, community belonging, and connectedness. And green space is associated with reductions in air pollution, noise, and heat. And there's been a growing momentum of interventions such as park prescriptions to promote park use in Canada, the US, as well as in the UK, where it's now being used in pilot projects within the National Health Service. And that's actually, I should just mention, that's actually an area that our team has been looking at, and we've been designing a protocol to test the effectiveness of a park prescription. It's a good time to be looking at this, as more and more cities are jumping on board to making commitments for expanding tree canopy to offset carbon emissions. In fact, many cities are now committing to 30 to 40% tree canopy over the next 30 years, so by the year 2050. But we have to remember, as these sort of policies roll out, this notion of green gentrification. So our policy is going to be rolled out in a way that will benefit populations that stand to benefit the most, or can they actually make health disparities worse because they're being applied to areas that are wealthier to begin with? And in fact, in this recent study, they found, if you look at the left, you see this wonderful road network that we see in Barcelona, and they have a whole greening program that has been underway since 2020. But even in a city such as Barcelona, they found that green gentrification happened, or greening happened at the same time that gentrification did. And even if you look at this box on the right, you can see that even in a city such as Copenhagen or Vancouver, that green gentrification, or that greening, tended to happen before gentrification did. So it was actually something that may have precipitated gentrification. We also have to remember that not everyone has the same access to green space or the same experiences. Not everyone uses these spaces freely and without being hassled. So this is an example of this is an article from the Globe and Mail, and it's the experiences of Jacqueline Scott, who was a PhD student at U of T, and she wrote about how every time she was in Toronto's ravine system, she was stopped by people and asked if she was lost, even though she had the gear of an experienced hiker. Nada Hussain, who's a PhD student at York, has been looking at ways to approach urban green space from a racial justice and health equity perspective. And so her recommendations are to resist romanticizing nature and green space, to assess structural determinants of health, and to engage meaningfully with people who are racialized, to understand their experiences and barriers to using these spaces. We also have to remember that structural racism can lead to access issues. For example, green space in neighborhoods that are lower income or racialized may be of lower quality. They may not be as well maintained, they may not be as safe, and they may have fewer amenities. And we need to sort of expand our concept of access. And she also recommends building solidarity between groups and documenting and sharing processes and actions. And now some cities are taking up a move to try and specifically target lower income and racialized communities. For example, Portland, partnering with these communities to plant more trees in low canopy neighborhoods, especially considering climate change, because low income neighborhoods have more heat islands. And so there's a lot more barriers to walking in these areas, and in terms of having resilience to climate change. Interestingly, there's been interesting work done in Philadelphia. This is actually the impact of greening strategies that came out of a randomized experiment. So they, working with the Horticultural Society of Philadelphia, South and her team, they randomized greening interventions within vacant lots. So the lots either received a greening intervention, a trash cleanup only, or a control group of lots that didn't have any intervention. And you can just see an example of some of the interventions that happen. So you've got a new little lot that's just in disrepair, and then is now made greener. And they actually found that people living near these green neighborhoods experience reductions in stress, depression, and even gun violence. So as we think about ways to get people moving and using the natural resources in the neighborhoods and opportunities for walking, we can sort of think of this sort of summary. So what I've shown you is that people who live in highly walkable neighborhoods appear to be less likely to have prediabetes, diabetes. They're less likely to develop high blood pressure or experience a cardiovascular event. But we have to remember that population level data is great at showing overall patterns of disease, and you can even zero in on the neighborhoods that have a greater burden of disease and an unsupportive environment. But we also have to remember that effects may vary based on the underlying susceptibility of the population. We have to be careful to consider other factors that address confounding, and remember that it's actually a bit of a complex interplay between different aspects of the environment that are happening. And in identifying solutions, we definitely need to look at the evidence, but really importantly, we need to engage populations living in high-need communities to understand the solutions that are meaningful to them, and then a lot more intervention work to actually understand what are the levers for change and what factors would actually really help people to become more physically active using their neighborhoods and other resources. So I think that the other take-home message is that interventions targeting the built environment might widen disparities if they are applied in an inequitable way. So we need to think about how these interventions are rolled out. I think a lot of cities are thinking positively about making healthier, more supportive environments, healthier communities. But again, we need to really think in a smart way about how we do this so that we can actually reduce health inequities and not widen them. So I'm actually going to stop there, and I'd like to just acknowledge all of the students and project staff, analysts, and co-investigators that have contributed to this work over the years. And I'll say thank you, and I'm happy to open up for questions and discussion. I think we have a good amount of time for that.
Gillian, thank you so much for a wonderful and thought-provoking talk. Maybe you can stop sharing the screen and we can open it up for questions. So please, if anyone has questions, please raise your hand or put it in the chat box. Just looking, and you can certainly turn on your turn on your camera. Well, while people are thinking of, oh, there we go. Jamal Taylor, please go ahead.
Hello, good afternoon. Thank you, Dr. Booth, for the presentation. I just had a question about the IPTW, or the inverse probability treatment weighting. I kind of went over really quickly, so I didn't really understand what that was.
Okay, sorry about that. Yeah, so what we did is we used administrative data for the population and compared those living in the high walkability neighborhoods versus the lower walkability. And I mean, what we traditionally do in research is we adjust for different characteristics of the populations living in different neighborhoods, and we just sort of adjust for them. In this approach, what we did is that we use propensity scores. So propensity scores kind of were developed to try and mimic a randomized trial, although they don't fully. What they do is that you can actually create a weighting structure that makes the two populations look the same in terms of the characteristics you know about. So what I could have shown is actually like a table 1 showing that you've got good balance between the two neighborhoods in terms of all of these baseline characteristics when you apply these propensity score weights. So that way, it's kind of like, you know, if you have a survey from Health Canada or Stats Canada, you create weights for the population to try and make them look like the general population. In this case, we create weights to try and make them look similar to each other. And in doing that, even when we did that, we found that highly walkable areas had a lower risk of developing diabetes. Interestingly, after going to the complexity of doing all that, we actually found that the effects were similar when we just did the old-fashioned adjustment, which was actually good news to know that, you know, you can just use the traditional techniques. But we did go through that exercise. I hope that explains it a bit better.
Yes, thank you.
Thanks, Dr. Booth. We have a question from Dr. Bernie Zinman. Go ahead, Dr. Zinman. Thanks for joining us.
Pleasure. Great talk, Gillian. You know, it's really puzzling that higher walkability is associated with more smoking. And so, you know, this smoking is a really powerful risk factor, probably, you know, in traditional studies, probably more so than exercise in the context of cardiovascular risk. So what can you give us more information on that? I think you have to solve that conundrum. Yeah. It shouldn't, you know, it doesn't make sense. And what was the magnitude? Was it like really a strong relationship?
Yeah, it was 26% lower, and it was kind of linear. It was 26% lower in the less walkable areas, less walkable areas. So high walkability, you know, more. Yeah, so Nick was sort of postulating there wasn't a lot of data in the literature to suggest that like tobacconists, like being near stores that sell tobacco. His work was really complex too, because I think I kind of alluded to the fact that we didn't see improvements in cardiovascular mortality, but we did see this huge benefit in terms of AMI and stroke. And one thing that was part of that was because the populations living in downtown areas, you can imagine downtown cities have very complex populations, like adjusting for income may not really quite address that. You have for one of our things about we're capturing out of hospital deaths, and there's a lot of concern that those might actually be picking up people who are having overdoses or suicides. And so you've got a lot of this sort of complexity. And in that case, it may be that some of the social disadvantage and homelessness, like you might be getting factors that are, it may be the populations, and they would have higher rates of smoking potentially. But there may be an access issue too. And it may be that some populations, South Asian populations and other immigrant populations actually can be maybe healthier in terms of some risk factors, and they often living in suburban populations, suburban communities. So you may have some populations who choose not to smoke and may have differences in smoking rates in other populations. So we don't know yet, but it's a great point. Yeah,
it's worthwhile looking at. And, there is another observation that's interesting. The highest smoking rates, when you look at provinces, is Quebec. And when you look at BMI, they have lower BMI. So smoking is associated with lower BMI. It's not a healthy thing to do, obviously, for so many thousands of reasons. But there is a relationship between smoking and BMI. And so you may want to look at that as well.
Yeah,
that's interesting. No, thanks, Bernie. It does definitely a perplexing trend. There's a question in the chat from Mark Peltier, Gillian, and he asks, in the research mix, what insights might there be about rural communities?
So we've focused on urban communities. My research institute is an urban institute, but I think that I think that walkability, as it's been constructed, is an urban concept. But I think that the fact that your environment influences your physical activity choices is important to all populations. And certainly living in rural communities, there may be other opportunities to walk in terms of rural areas, but there may also be a greater dependence on cars. So I think, Candace Nikiforuk at the University of Alberta has done a lot of work on rural communities, small towns, looking at walkability, and looking also at more sort of what we call microscale, or sort of local changes that would improve walkability, such as things like, in small towns, having park benches and sites for people to go. So I can't say from my research, but I do think that this notion of how you're influenced by the opportunities you have in your environment are probably universal, but certainly the work I've done is focused predominantly on cities.
Thanks, Gillian. Maybe while people are thinking of other questions, please raise your hand, put it in the chat. I had a question, Gillian. So I was really interested in how you touched on the fact that it's when you look at the different ways in which people engage in physical activity between, active transportation during their non-leisure time, to go to work or to go do errands, that kind of thing, versus leisure physical activity, what is becoming increasingly clear is that the impact of walkability on health seems to be greater around active transportation. And I guess brings up a couple of issues. One is around the rural versus urban situation. I mean, I imagine that in rural communities, it would be very hard to make transportation much harder to make transportation to workplaces and other sort of places of interest more active because of the lack of density. But the other piece is around some of the levers and the interventions that people are thinking about, like making, increasing trails for people to go and walk in parks and in nature. I mean, that's all tends to be leisure, right? And then the other piece is around, community-based, exercise and physical activity programs and walking groups, again, all leisure. So to what extent have they shown, has there evidence that targeting, because we know we need to target active transportation. I mean, that's pretty clear, but what about work that's shown that targeting leisure activity has been linked to better outcomes? Do you know what I mean?
Yeah, so I guess, so we definitely know that all physical activity in whatever form is linked to better health. You're thinking about how policies or interventions targeting leisure versus active transportation. So it's a little bit difficult to compare, but I think that, there's evidence that both have an impact on, or that both can be potentially successful in promoting physical activity. Let's put it that way, because we know that promoting physical activity and people becoming more active is associated with those downstream benefits. I think that, so if you look at, for example, the PARC prescription data, so colleagues of ours in Sydney, Australia, have done a meta-analysis of PARC prescription interventions, or actually that was more like a little broader than that, nature-based interventions, finding that that overall they do increase step counts. They're kind of a heterogeneous, sort of targeting wide groups of people, including people with extremes of age and so on. But overall, there seems to be a benefit, and benefits in terms of mood and other factors. And presumably a lot of them kind of focused on leisure time activity. But I do think that there is a potential missed opportunity for using parks and green space for active transportation. I mean, if you look at the ravine systems and the way that these natural forests and trails and parks are laid out in different cities, some of them potentially could be connected in some way that would allow a more longitudinal cycling path. I mean, they are in some ways and being used that way, but even like the city parks, there could be some ways of doing that. And I think people don't necessarily think about using, shortening your trip by crossing a park. I think people who walk a lot do. And I think that those sort of interventions can actually make a difference, but that means cities actually kind of actively thinking of how they can link these spaces. Because I think more and more, and if you're someone like me, I did cycle to St. Mike's for a little while, particularly when I was younger, but then I took it up again. But a lot of people don't feel safe on the roads in terms of cycling until you actually get to the place where you have better, safer infrastructure. And I think that offloading those spaces with spaces that are green or can be linked in a way that makes people more comfortable would be useful.
Thank you. That's great. Dr. Zinman, please go ahead.
I have another question. So one of the things, it's interesting that walkability, looking at different countries. So Saudi Arabia, the reason there isn't a lot of walkability is 40 Celsius outside. Yes. And so have you looked at climate and seasons? Obviously, the parks and everything, they don't change between summer and winter, but certainly climate. And so the average temperature, and would you be able to draw a graph showing that in very hot environments, there isn't that much walkability, or maybe you have to measure it within malls. So that would be an interesting thing to look at, just like people have looked at, latitudes in relationship to multiple sclerosis, but they're all, this is a more obvious question.
Yeah, so I didn't show this data.
Did I miss that?
But no, I didn't show it actually. But so we looked at this a couple of different ways. So there's clearly a relationship between air temperature as well and diabetes risk. So we looked at the 30-day mean temperature prior to screening for gestational diabetes and found that colder temperatures were associated with lower risk of gestational diabetes and higher temperatures associated with increased risk. So there's a number of different factors at play. And that relates to insulin sensitivity and possibly brown fat. But we actually when we looked at walkability in gestational diabetes, we stratified by season. And a lot of people say, oh, but it won't have any benefit in winter because no one will go outside. But people who use active forms of commuting tend to do it throughout the year. And actually, the benefits of gestational diabetes were similar in different seasons. So in winter versus summer versus others. But your point's well taken that when we want to think about walking and physical activity promotion, we have to think of indoor environments as well, especially in Canada. Although I had an interesting conversation with Jackie James in our division she said that she tells her patients in this winter time with diabetes to put cleats on their shoes and use a walking pole, and so continue to walk. even in natural environments. So I think,
Right.
we had, obviously we would need some flexibility in our kind of environment, but these are important things that we need to consider in terms of counseling patients, in terms of opportunities that people have.
Are there more pedestrian accidents in walkability areas? In other words, you had that same fear. You didn't think it was safe. But is there any
cycling.
evidence of an increased risk of having a motor vehicle accident in walkability areas that involve pedestrian, not car to car, but pedestrians getting injured?
Well, I think there's some, sorry, I don't have this exactly at my fingertips, but you have to remember that highly walkable areas that have more stores, services, cars idling, and people going there and working there as their daytime work, have a higher volume of daytime population as well, and higher volume of cars. So they may have I think so. And I'm not sure exactly.
But it's a risk benefit. I mean, if you're really, the risk of being run down is 100-fold higher in walkable areas. And it probably isn't, but I think it's something you need to know.
Yeah, for sure.
There was and I'll finish. You may have been there, Bernie and Gillian, at Dr. Mohan's talk at Citywide Rounds for Endocrinology a few years ago. He's from India, and he had done that study where he, wondered why people in these villages in India were not walking outside. And they said, because it's too dangerous. I'm going to get hit by a car. I'm going to get, my wallet stolen. And so they ended up creating these, you probably know the work, they created these walking paths for people. And apparently the walking rates, went up substantially, and diabetes, the increase in diabetes that was seen across India was sort of attenuated in these walkable areas. So anyway, it just speaks to your point, Bernie, about, creating safety. We have to think about safety as well.
Absolutely.
Yeah, it's interesting. The same thing was done in Sandy Lake. It's interesting. We wanted people to walk in Sandy Lake, and everybody drove around this circle. And the chief and council said, we used to have walking trails, and they built them themselves again. Now, whether it's had an impact, we'll have to wait and see. But they built these walking trails with railway ties across a very inhospitable terrain. But the shortest distance between 2 points is a straight line, not a wide circle. So. I think you have to be imaginative and introduce things.
Yeah, I agree. I mean, it kind of shows it. I mean, we assume if you build it, they will come, but you really need to know there's so many different complex factors that people are, dealing with, that we need to consider in terms of creating these spaces.
And that's, that just brings us full circle back to one of the major priorities for us at the network, is to really hear from the citizens in the region around what are the preferences, barriers, and priorities around making their environments healthier. So we're out of time. So I would like to end by thanking Gillian Booth for her wonderful presentation, and for the very provocative and interesting discussion that took place afterwards. Please, thank you everyone for joining us today, and again, join me in thanking Gillian for a great talk. Please ensure you complete today's evaluation for the session. It's been added to the chat pod, and it will also be sent directly via email to the participants. So just quickly, our next event will be the first of the year for the Network for Healthy Populations and BBDC joint clinical and population research in progress rounds, where we have trainees present their research in progress and elicit feedback from our community. And these rounds are going to take place on February 27th from 12 to 1. Again, virtually, and we will send you more information closer to the date regarding speakers and how to register. So once again, we hope to see you all there, and thank you again for joining us. This concludes our seminar session today.